Good evening, Shweta. Can I share my slides?
Yes, doctor, go ahead, please. Doctor, kindly full screen.
Yeah, Rajshekhar sir. Is my slides visible and is moving? My slides are moving.
Yeah, 100%. Make it is slideshow.
Okay.
Slideshow.
Shweta, are you satisfied?
No, slideshow.
I have put it on slideshow.
Okay, yeah. Now come.
Is visible?
Nicely, sir. Very nice.
Okay. Shweta, can I stop sharing?
Yeah.
Yes, doctor, you can stop sharing now.
थोड़ा टेंशन हो जाता है राजशेखर सर. क्या होता है ना कभी-कभी अभी that slide share doesn't work.
उस समय बड़ा टेंशन आता है.
For that, this doctor kindly share the PPTs to me. In that case, I can help.
Yeah, I will send it. कैसे send करेंगे?
post5@dipindia.org.
Post.
I mentioned on the WhatsApp group. You can see.
Okay, let's see. पोस्ट पर कहाँ खोजेंगे अभी ये WhatsApp group? Shweta, we are not used to all this.
पूरा राजशेखर सर पूरा स्लाइड्स है?
पूरा नहीं है, अपना कर लिया ना.
सचिन के पास है, पूरा एक बार भेज देते तो ठीक ही हो जाता है.
हाँ, पूरा भेजा नहीं. नीचे देखना पड़ेगा. सर क्या बोली वो होस्ट 5?
Post5. I'm mentioning on the chat box.
Okay, mention it. Because what happens, we all no sir, এটা রূপাশী বাংলা ওটা লাস্ট ইয়ার হয়েছে না? হয়নি?
Yeah, last year too we did the same thing.
সেম গ্রুপ দেখছি ওই যে রূপাশী বাংলা.
We did one for West Bengal last year also. These are the remaining part, that mop up one.
That রূপাশী we have done it.
तो सचिन के पास होगा ना पूरा?
हाँ, पूरा सचिन के पास.
सचिन के पास होना चाहिए. पूरा स्लाइड्स भेज देने से हो जाता पीछे से. सचिन कहाँ है? सचिन नहीं है. I think Arun sir has joined.
Yeah,
Good evening, Dr. Arun.
Good evening, sir. Good evening.
Good evening. How are you, sir?
I'm fine. I'm fine. How are you, sir?
Namaskar.
नमस्कार जी।
नमस्ते सर।
ये तो सचिन सर जैन।
सचिन ज्वाइन हो गया, सचिन किस टाइम ज्वाइन हो?
सचिन भाई,
Dr. Sachin, will you like to test run your slides? And
No,
Dr. Arun also.
I will share my screen.
yeah, yeah,
If
please,
enable.
please.
Go ahead.
Please tell me if they are visible.
Yeah, slideshow, doctor.
I'm just doing slideshow.
Yeah, perfect, perfect. Can stop sharing.
Oh, Bhaskar sir has joined. Good evening.
Good evening, sir. How are you?
एकदम
गुड
perfect.
इवनिंग सर,
Sir.
भास्कर सर। गुड इवनिंग
Ah,
सर।
good evening. Namaste,
Every-
namaste.
नमस्ते सर।
Everything okay? Stable?
Yes, sir. Yes, sir. Yes, sir. She is fine. Fine.
Okay,
Good
fine.
evening, Dr. Bhaskar. Good evening.
Good evening, sir. Good evening. Namaste.
भास्कर सर, आपके पास तो पूरा स्लाइड्स है ना?
Yeah.
तो कैन यू सेंड इट टू DIP फॉर बैकअप इफ नीडेड? किसी का अगर स्लाइड्स गड़बड़ हो जाए।
Okay, okay.
Oh, Shweta has put it in the chat box, that number, that email.
Post
Post 5. Yeah,
5, okay.
yeah, 5.
I'll try.
We have checked, our slides are working, but still.
Okay, okay.
Sir, this is the last of the series?
No, sir. Still
Starting of the series.
At 30, I'm what to do. Responsibility is given. We have to finish.
Yes, yes.
Sachin is there.
Arun
He's,
sir, this year started, sir. How will you do the last?
Sachin, are you there?
Sachin has logged in, but we haven't seen him as yet.
Got my point, sir. Atanu sir, it is starting of the year, so starting of the series.
राजशेखर सर, आपको पास एक मैसेज भेजा है आपके
एक
पास।
मैं-
अभी नहीं, पहले भेजा है, 15-20 मिनट पहले। अब भास्कर
वो
सर
मैं-
को भेजेंगे रात को।
ठीक है सर।
What is that special message? Now I am.
आइए, अभी भेज देते हैं आपके पास।
नहीं आया मेरे पास।
नहीं आया फ्लायर? नहीं आया?
नहीं आया।
एक फ्लायर
लास्ट 19 मार्च को एक फोटो भेजे, हमारा
अच्छा।
नोएडा का फोटो भेजे बस।
ना नोएडा वाला नहीं। अच्छा ठीक है, भेज।
उसके बाद कोई मैसेज नहीं।
आपको 4313 वही नंबर है तो ना राजशेखर सर?
This number keeps changing, sir.
नहीं सर, एक ही बार।
4313 जो है वो नहीं है?
नहीं है सर, मैं दे रहा हूँ।
आप हाई करो भाई, आप हाई करो आपका नंबर से। अभी
अभी
वही नंबर पे भेजते रहे।
सर उनके पास कितना नंबर है उसको ही मालूम नहीं।
बदनाम हो जाएगा सर।
वही लग रहा है, गया नहीं क्यों बोल रहे?
नहीं सर, वो रखा हुआ स्टैंड बाय के लिए, वो हॉस्पिटल का नंबर था।
तेंदुलकर सर आ गया।
आप लोगों ने काम लगा दिया सर अभी।
सचिन
अभी
Yes.
जब आप भास्कर सर को बोलते हैं, भास्कर सर बोलते हैं सचिन करा रहा है ये सब इतना कुछ, और जब आप सचिन को बोलते बोलते भास्कर सर करा रहा है.
so that much we have rapport, sir.
Yes, sir. That is there. No issue.
That is
Now people are remembering me Sachin Patil and Bhaskar Sinha, sir.
yes.
Some had called me, are you from ID chapter? No. I am just doing my job. Sir, one minute.
नहीं सर, भास्कर सर का नॉट
Hello,
राइट
sir.
चैप्टर, इन चैप्टर में डल हो जाएगा. $7:30.
7:30. You can start, I think. Got your number, Rajsekhar.
Sir, I am a
Welcome, Shahrukh. He's from Ruposhi Bangla, one of the host branches today. Okay.
Hi sir, good evening.
Good evening. Good evening.
Sir, you unmute yourself. Sir.
All Shahrukh, all the others have logged in from another link to the viewers link.
কয়েকজন আমরা একসঙ্গে বসেছি আর বাকিরা আলাদা আলাদা.
Okay. So they are doing it in a hybrid mode. Bhaskar sir, this is a unique one. Some of the members of Ruposhi Bangla, they have collected in one place and they have logged in from one place. The others have logged in from different places. So this is the first hybrid mode of hepatitis A module.
Kosita is also present.
Okay.
Good evening, sir. Good evening to all of you.
Good evening.
Sir.
Good evening. Good evening. Sir.
IMP clubhouse.
Also our branch president, Dr. Seat is present.
Good evening.
Namaste. Good evening.
Namaskar. Namaskar. And Kalpana Di has joined. She's the president-elect of WBMP.
নমস্কার, গুড ইভিনিং সবাইকে.
Namaste, sir. Namaste, madam. Namaste.
নমস্তে.
Sachin, you can take a picture and just say that this is the first hybrid mode.
He's talking to somebody.
Okay. मिला है राजशेखर सर?
मैंने भेजा आपको.
हाँ भेज दिया.
हाँ
हम उसमें भेजा है आपको.
हाँ श्योर.
ठीक है.
অতনু স্যার ওটা ডিলিট করে দিন, 0টা এটা
हाँ ওটা delete कर. I delete. ठीक. So first is I think we can start.
yours only first I think, sir.
Hello. I am the first.
Yeah,
Followed by.
myself.
Okay. But Shahrukh, we can start now.
Sir.
শুরু করতে পারি তাহলে?
Yes, you start.
First welcome our both the delegates and the faculty, and ask Dr. Bhaskar sir, Bhaskar Sinha, who is the national coordinator for this module, and followed by Dr. Sachin Patil to say a few words. Shahrukh, you can start now. Sir, shall we start? Bhaskar sir.
Yes, sir. Yes, sir.
Unmute yourself, Shahrukh.
Sir, Indranil sir has joined.
Oh, Indranil has joined. Welcome.
Yes, he will start, sir. All
Okay,
proceedings.
Indranil,
Nothing.
you can start.
Yeah, I'm sorry that I was late in joining because there were some problems in my joining machinery.
No problem, sir.
No,
You have joined on time.
Not really, just 1 minute plus minus.
Sir, welcome you all to this great program of the DIP platform, and West Bengal is happy to be with you all. we from WBAP would like to thank all the technical experts of the DIAP along with all the doctors who are involved in it. And the topic is also very good because most of us have teenagers and are staying in hostels. So I think hepatitis A is a very topic which is very useful now. Hello, can you hear me?
Yes, sir.
Okay. And so therefore, just while starting, let me call on Dr. Bhaskar Shanai, who is the national coordinator of this module. Dr. Bhaskar Shanai is a leading pediatrician of repute, and he has been with the IIP for so long. I would request Dr. Bhaskar Shanai to just say a few words on today's module.
Thank you, sir. Thank you, the whole of West Bengal Pediatrics Academy for taking up this module and trying to disseminate the knowledge. In fact, this is as Dr. Indranil has told, it is a very good module. And this module covers starting from epidemiology to how the changing epidemiology is affecting the presentation of the disease. Then what are the clinical features? And though we say that hepatitis A is very, doesn't cause complications, but there are many cases wherein the cases have hepatitis A has caused a lot of complications, 10 to 15% of them. And there is a huge series which is published from Pune, wherein they have found that out of all the fulminant hepatitis, it is hepatic failure. About 50% of them are due to hepatitis A. And especially so when this is occurs on a patient who is already having a chronic liver disease and so many underlying causes, and they're at a higher risk. So with that, this module has been created, and leading experts from all over the country, Dr. R.K. Gupta, Dr. Rimjim Srivastava, Dr. Srikant, Dr. Ravi Shankar, and many more people have participated in this module, and that has become a very good module and has been well appreciated. And this module also talks on the prevention of the hepatitis A, and we have 2 vaccines, killed and live vaccine. And this module discusses how best we can optimally utilize the existing vaccines in preventing such a disease. So we have excellent faculty today who are well experienced, and they will be good. And these are the case-based modules. Most of the lectures are case-based, and that becomes more interesting. So with that, I wish you all the best and happy learning. Thank you once again, West Bengal Academy and Dr. Atanu and Dr. Indranil and all the stalwarts who have assembled here for giving this opportunity to me. Thank you so much.
Thank you, sir. Thank you for formulating such a beautiful module. Next is the joint coordinator of the module is Dr. Sachin Patil. Now, Dr. Sachin Patil is also a very great IIP follower, IIP member, and he is also the national coordinator of the picnic module of IIP. So I would like request Dr. Sachin Patil to say a few words about the module before the module starts.
Good evening, everyone. Am I audible, sir?
Yeah, you are audible, clear.
Good evening, everyone. First of all, thank you so much, the host branch, especially IIP State Branch of West Bengal, Silkudi, and Rupshi Bangla, for giving the opportunity for conducting this module. Regarding modules, everything is well explained by my mentor, Dr. Bhaskar Shanai, sir. And definitely, you all people will love it. It's hardly just 2.5 hours. And interesting case scenarios are there. And thank you so much, my co-faculties, for giving a valuable time for conducting this module. And I am very much fortunate being a joint national coordinator under the leadership of Dr. Bhaskar Shanai It is great feeling to announce that almost we have completed 33 to 34 webinars till now. Only just 2 are remaining after this. After that, this module will be on the IAP platform for every participant forever. Thank you so much. Now, over to you,
thank you,
Indranil,
Dr.
sir.
Sachin Patil. Thank you, Dr. Sachin Patel. I see from the participant list that the president-elect of West Bengal Academy of Pediatrics, Professor Kalpana Datta, is also here. Can I request Kalpana Datta to say a few words, please?
Good evening, everyone, and welcome to this platform of Hepatitis A webinar. It's a very important aspect nowadays. You know, the government of India is running the control program, eradication program of Hepatitis B. So it is a high time to also, we should aware about the Hepatitis A infection and control when it's easily controllable. As we know, it is a fecal-oral disease, and we have a very effective vaccine against it. So we should have a nice discussion, I think, and everyone will enjoy today's academic session about the hepatitis A. I'm not going to waste much more time. Please start the webinar, and we'll love to listen from the experts. Thank you.
Thank you, Professor Kalpana Datta. Now, before the experts start speaking, the presenters start speaking on hepatitis A, I would take the opportunity to welcome all the presenters and to give a short introduction of all, so that there is no interruption in between the PowerPoint presentations. The first presenter is Dr. Atanu Bhadra. He is from West Bengal. He has been the CIP VP last year. He is a very well-known name in West Bengal, and he has done very much grassroots level work for the IAP in West Bengal and also throughout the country. Welcome, Dr. Atanu Bhadra. And the next speaker after Dr. Atanu Bhadra is Bachu Raj Shekhar, who is from Andhra Pradesh. He has been the EB last year, that is 2021 of the CIAP. Welcome, Dr. Bachu Raj Shekhar. And the third speaker today will be Dr. Arun Prasad. Dr. Arun Prasad is basically a pediatric gastroenterologist and a pediatrician of repute. He has been the CIP EB this year. Next speaker is from West Bengal again, is Dr. Pinaki Chakraborty. Dr. Pinaki Chakraborty is also a leading pediatrician, and we welcome him to the IAP-DIP platform to present his PowerPoint presentations. And the last speaker today is Dr. Devjit Kumar. He is from Guwahati. He has also been a very leading pediatrician and a IAP staunch worker. Now, I welcome all of you and would like Dr. Atanu Bhadra to start the presentation. At the same time, I would like to request Dr. Sachin Patil to end the program with a summary after all our speakers have finished. Thank you so much. Good evening to all of you. And please, Dr. Atanu Bhadra, can you please start the PowerPoint presentation sharing?
Thank you, Dr. Indranil, for a crisp and brief inauguration. And we'll also welcome Dr. Sharup and Dr. Sheet on behalf of the Ruposhi Bangla branch. And Indranil, this is the first time we are having a hybrid mode because they have collected in one place and they have logged in from one point. So I think Bhaskar sir and I had been discussing that probably this would be the first time a hepatitis A module being done in the hybrid mode. So okay, so I hope my slides are visible and it's audible also. I just mild correction. I think Pinaki is not from West Bengal. Pinaki is from, I think, Silchar. If Sachin can correct me if I am wrong. Yeah, so he's from, and he will be joining in a bit later. So as we start the module, thanks to Dr. Srikant, who had been instrumental in developing this part of the module. And of course, he is a pediatric gastroenterologist. So he's also one of the other speakers today, Dr. Arun. And COVID incidentally had made us interested in many things. One is, of course, the virtual mode, and the other, of course, in some RNA viruses, we had been interested in developing vaccines for RNA viruses, and we had been studying much for the last 2 years. And in fact, hepatitis A virus also incidentally is a RNA virus, and we have, as Dr. Bhaskar sir had said, we have we have 2 very effective vaccines against them. So the discussion today would be just to the point and case based. and it is a RNA virus. It is a single serotype. That is why the vaccines are very effective, because when there are multiple serotypes, when there are differences in different strains, there is shifting and changes in the strain, we have difficulty in finding out whether the particular vaccine works or not. That is what is happening with COVID. But here the serotype is one, and that's why one vaccine is very effective for all the diseases, for all the whole spectrum of hepatitis A virus. And transmission, as we all know, going back to our college days, it's via the fecal-oral route or by injection of contaminated food or water. Remember, why it's important that this virus can survive in contaminated media for months, and that is why it even remains stable and is resistant to acid, and that is why it's very it is a very potent contaminant for both the water and for the water supply. Incidentally, earlier in the old water supply system of all the metros had the sewerage lines and the water supply line, drinking water supply line, side by side in many places, and that often led to contamination. And that is what Indranil was referring to when he said that we had outbreaks of hepatitis A in our hostel days. So what's roughly the life cycle of that virus is that it is taken into the body by oral injection. It enters the virus enters by the gut mucosa. It replicates in the intestinal cells, reaches finally the liver by the portal blood. There is replication there. The progeny is released to the bile. There is viremia, and finally it reaches the intestine and shed in feces. So the moment it's actually the time period just before the shedding occurs, the viral shedding occurs in the feces, the viremia occurs before that. So this time cycle is remember that all this cycle occurs in fact weeks before the onset of symptoms. So before you realize that we have this disease in hand, probably all this has already happened in the body, and this person had been shedding, or this child had been shedding feces shedding the virus in the stool. So remember the pathogenesis of hepatocyte injury. It has two divisions. One is the cytopathic part and the non-cytopathic part. And remember the final injury to the liver cells is immune mediated. The average incubation period is 30 days, and it can range from 15 to 50 days, but its average is 30 days. The signs and symptoms normally occur. They normally occur 3 to 5 weeks of exposure, within the 3 to 5 weeks of exposure. And first the HIV viremia, the hepatitis A viremia occurs, followed by shedding in the feces. There is a rise in the short-term increase in immunoglobulin IgM and a gradual long-term increase of the IgG antibody response. And as we had been discussing, there are two phases. The first one is non-cytopathic stage. The viral replication occurs exclusively in the cytoplasm of the liver cells. The HIV is released, the hepatitis A virus is released into the bile, and there is fecal shedding of HIV. All this is in the first phase. In the second phase, there is fluoride portal zone infiltration. The whole structure of livers is disturbed. There is necrosis, there is erosion of the limiting plate, and all of them, these are caused by the immune system, and it's a process which is mediated by the HL restricted and HL specific CD8 lymphocytes and the natural killer cells. And that's the most dangerous part, where we have that leads to liver failure in some cases. So this is the most important slide that in the whole module, and that should be kept in our mind whenever we are trying to diagnose a hepatitis A infected child in our chambers. There is first fecal HIV. The viremia occurs a bit earlier, then the ALT rises after that. So getting a normal ALT in the initial phase should not rule out that this child is not suffering from hepatitis A. And after the ALT peak occurs, we have IgM peak, and then the IgG HIV peak, and that IgG antibody peak finally remains for a longer period of time. So this is the very interesting slide that will help us all throughout our diagnostic that diagnostic attempt. So it's common in low and middle income countries with poor sanitation, but of course it does occur in developed countries also, where almost many of the children, they get infected with hepatitis A virus. That's for the low and middle income countries. But in the highly developed countries, we have hepatitis A among adolescents and adults in high risk groups, including populations which inject drugs, that is those who are dependent on drugs, men who have sex with men, and people traveling to areas of high endemicity. That is a person coming into a high endemic zone and getting infected with hepatitis A virus, and also in isolated populations such as closed religious groups. In the United States of America, large outbreaks have been reported among persons who don't have a home, live in shelter homes, and that's the reason of why they get infected. So the transmission, one is the fecal-oral route, one is the waterborne outbreaks, and they can also be transmitted to the close physical contact, as we have found out in the earlier discussions. And outbreaks generally occur when where institutions where children are there. In fact, childcare staff members develop symptoms. Then we come to know that probably some of the children are infected, because most of the children, when infected with HIV, are asymptomatic or have very non-specific symptoms. So the potential for broad exposure is compounded in childcare centers that include children who have not yet been toilet trained. So the lack of toilet training, the presence of asymptomatic or non-specific symptoms for the children leads to late diagnosis and spread of the disease among the staff members who care for these children. So the incubation period, again, is we all know is approximately 30 days. Symptoms range from non-specific, mild to severe ones: fever, malaria, loss of appetite, diarrhea, all college, undergraduate days, the undergraduate chapters. But remember that not everyone who is infected will have all the symptoms. And adults and adolescents, they have signs and symptoms of illness more often than children. So children are more prone to have asymptomatic disease. Infected children under 6 year age do not usually experience noticeable symptoms. So only 10% of them, in fact, will develop jaundice. So many times it is very difficult to diagnose, and even we miss these children who are infected with hepatitis A virus, because they'll fail to develop jaundice, and that's why they do not come to a chamber or do not seek the attention of a doctor, and that's why we miss them. Hepatitis A normally doesn't relapse, but sometimes in rare occasions it can relapse. But normally the relapse is just after the first infection. That is, a person who was recovering falls sick again with another acute episode, and normally this is followed by lifelong recovery. So who is at risk? Anyone who has failed to been vaccinated, or who are living in areas of poor sanitation, lack of safe water, living in a household with an infected person, or traveling to areas of high endemicity without being immunized. So a person, the travel advice should be for a person who are traveling to a different country, check the endemicity of that country and get you immunized before you move to that country. So the virology, we all know that it's RNA virus. It's a single-stranded RNA virus, and they have 4 defined genotypes, but there is only one serotype, and the virus is stable at low pH and moderate temperature, but it is inactivated by high temperature chlorine and formalin. This is very important, that if you treat your drinking water with chlorine, that as we normally do in all large and small cities now, so the water supply is safe from this hepatitis A virus. So this prevalence, you can see that this is a pretty a bit old map. It shows high endemicity in hepatitis A. In fact, we are moving from high endemicity to medium endemicity, and that's very important for hepatitis A prevalence, and that is why we're spending so much time on studying this disease and studying and asking children to get vaccinated. So this is again a reflection of the earlier curve that we had been shown. That's we get a viral infection, then we have viremia, then we have HIV in stool, then we have the ALT rises, the liver enzyme rises, and then we have antibodies coming up, the IgM first and then the IgG. So the clinical feature again under 6 years, they are asymptomatic, even they might fail to develop jaundice. And during the prodromal period, the amino transfers are elevated. So if you get a serum LFT done during this period, we'll probably have an idea of say that something is wrong and probably the enzymes are raised, liver enzymes are raised. The jaundice usually occurs 1 week after the onset of the other symptoms, and along with it, coluria or yellow urine. That's the most common presentation which alerts the parents, and the child is brought to us. It's the high colored urine, and that occurs, remember, almost 1 week after the onset of symptoms, and there would be mild hepatomegaly. So the clinical features less than 6 years, again, this is we are in fact emphasizing the point that 30% of infected children younger than 6 years only will have symptomatic hepatitis. That is, the other 70% will have asymptomatic hepatitis A. That's the majority part of the young children will fail to have symptoms. Jaundice, if it occurs, it usually lasts for less than 2 weeks, and conjugated bilirubin and amino transfers return to normal within 2 to 3 months. So no hurry in getting another serum LFT done. We have to wait for 2 to 3 months for the raised enzymes to come down to normal. So if you do it before that, probably you'll still get a raised level, though the child has recovered from hepatitis A. So for adults, the clinical features are that 80% will have hepatomegaly, 70% of the jaundiced, and 40% will have to be hospitalized, and symptoms might last for more than 6 months. So that's a pretty long period. We often think that hepatitis A is a very mild disease and it will go away by itself. Well, it might go away by itself, but also it might lead to acute liver failure. It might be a prolonged period. It might be there for 6 months, and the liver enzymes may derange for 2 to 3 months. So acute liver failure, though it might occur in 0.3% of children younger than 14 years, but they are normally secondary to HIV infection in those with underlying liver disease, such as hepatitis C or Wilson's disease or autoimmune hepatitis. So it's not so very innocuous. The disease can lead to hepatic failure. For the extrahepatic manifestations, again, you can go through the list. It's vasculitis, arthritis, optic neuritis, the transverse myelitis, encephalitis, bone marrow suppression, and evanescent maculopapular rash and arthralgia. So you see, actually, what we have in mind about the hepatitis, it's not so very simple. You can have a plenty of different spectrum of symptoms and manifestations, which can alert you that this child or this adolescent might be suffering from hepatitis A. So these are the Indian data coming. This was published, and hepatitis A virus-related pediatric liver disease burden. It was fairly large. A large part of the liver burden was due to HIV infection, and this is the flow chart where you can see that if you go for IgM HIV serology testing, you can find out one group with acute viral hepatitis, one group coming up with acute liver failure, and one group coming up with acute on chronic liver failure. And of course, where we have to think of liver transplantation sometimes. So these are the data from intensive care unit. It's a pretty crowded slide, so no need to memorize it, but just to get it into our mind that the hepatitis A is not such a very simple disease, and it might lead to all of these dreaded complications and might need liver transplantation. This is a clinical presentation of classical clinical presentation. Typical manifestation, atypical manifestation would be like prolonged cholestasis, relapsing hepatitis or a biphasic illness, autoimmune hepatitis. also. The extrahepatic part is, of course, autoimmune. It might lead to autoimmune hemolytic anemia, pure red cell aplasia, acute reactive arthritis, and a host of other complications, including acute kidney injury. So the management is this basically supportive care with early detection as early as possible, keeping in mind the time period that we had been talking about, when you get a viremia, when you have to test for the liver enzyme, and when you have to get a stool culture done. So early detection, appropriate support, monitoring of the acute illness, prevention of the disease spread to susceptible individuals, and management of hepatic encephalopathy wherever they are present, they are present in some cases, and raised intracranial pressure also should be managed proactively. The associated complications should be taken note of, and they also should be managed separately. And finally, liver transplantation may be needed if there is deterioration in the clinical condition. So there is no specific antiviral medication, no dietary restriction, no glucose, and nothing that we used to prescribe earlier. No, but remember that from now on, after this module, we won't need any antiviral medication, no dietary restrictions, nothing, no glucose or glucose water or anything. Now, just mention that what is the prognostic model? We have an Indian prognostic model where hepatitis A induced pediatric acute liver failure for the acute liver failure, and there are three major criteria. One is the presence of grade 3-4 hepatic encephalopathy. We have INR greater than 3.1, and jaundice to hepatic encephalopathy interval more than 10 days. If two of these three criteria are present, then probably this child will need a liver transplantation. So this is a very useful bedside one, probably mainly used in the ICU, in the intensive care units, where you can probably identify whether this child will need will lead to acute liver failure, and there will be need of liver transplantation. So now we'll just have, we'll breeze through some case scenarios. The first one is an 8-year-old just crossing the 6-year barrier, and prior to, he had a low-grade fever. Now he had come with jaundice and recurrent vomiting, anorexia and malaise. Examination showed icterus, mild hepatomegaly, no ascites. Lab parameters, of course, we have a higher bilirubin level, SGOT, SGPT in terms of thousands, and we have albumin of 3.4. USG shows peribulbar edema. The CBC and electrolytes are normal. Diagnosis, of course, is a classical presentation of hepatitis A. Most of the children presenting to us or adolescents are, in this case, in fact, represents the most common presentation. And the management, supportive one, we may have to give antiemetics, no dietary restriction, outcome as expected, that there would be good recovery and discharge within a few days. Now, case 2 will reflect a 10-year-old boy with jaundice, vomiting, and excessive sleepiness, and that should be the red flag sign for this case. Prior to that, he had low-grade fever, anorexia, and malaise. He had not passed stools for the last 5 days. And on examination, there is, of course, icterus, mild hepatomegaly, no ascites, and had grade 2 hepatic encephalopathy. People were 3 millimeter reactive, no signs of raised intracranial pressure, and there are flapping tremors. So again, we had the lab parameters. The liver enzymes are raised in thousands. The bilirubin was raised a bit higher than the other case. The CBC again is normal. Of course, the diagnosis is hepatic A induced acute liver failure with grade 2 hepatic encephalopathy, no evidence of raised intracranial pressure. Management is supportive. We have to give antibiotics, lactulose, vitamin K, nasogastric feeding, and normal diet. And outcome normally is recovery and discharged even for this hepatitis A induced acute liver failure. Let's look at case 3. Again, this boy had presented with jaundice, anorexia, vomiting, as these are the non-specific findings. Then we have excessive sleepiness, combativeness, and altered sensorium. Now, this is pretty serious. Of course, we are thinking of hepatic encephalopathy also in this case, and this is definitely grade 3 with brisk reflexes, plantar bilateral going up, pupil is dilated 6 millimeters, sluggish and reactive, and lab parameters, liver enzymes raised pretty much like the previous phase. Now here we have a diagnosis of hepatitis A induced acute liver failure with grade 3 hepatic encephalopathy and raised intracranial pressure. So this is again, the management is supportive. We have to give lactulose, antibiotics, vitamin K, nasogastric feeding. Mannitol is needed for raised intracranial pressure. 3%, or you can give 3% saline for the same thing, and mechanical ventilation with propofol. And outcome is referred to a transplant center with all transport precautions. Liver transplantation was done with successful outcome. So this is how it can present. This child presented and of course needed a liver transplantation. So case 5, here again a 6-year-old girl diagnosed with acute hepatitis A with no liver failure, managed conservatively, was admitted and then finally discharged. But on follow-up, she came up with a rising bilirubin and severe pruritus affecting her sleep and daily activities. This is a case of acute hepatitis A with a complication that's prolonged cholestasis, and it suggested a hemolysis. Some sickled RBCs were found, and HPLC was done. We are alerted, and HPLC was done, and sickle cell trait was diagnosed. So again, the management with UDCA, cholestyramine, fat-soluble vitamin supplementation, folic acid, and adequate hydration, outcome was recovered. So whenever we have presentation of underlying hemolysis in cases of prolonged cholestasis, we must look for G6PD deficiency, thalassemia trait or intermediate, and also sickle cell trait. In this case, we had sickle cell trait, and that was diagnosed. So whenever there is presentation of prolonged cholestasis, and we must go for we must have a workup to find out whether any of these are present. So the key facts are that it's an inflammation of the liver. It can cause mild to severe illness, and hepatitis A is transmitted, of course, through fecal-oral route or through the contaminated food and water. Almost everyone recovers fully from hepatitis A, and once you have recovered, there is lifelong immunity. However, a very small proportion of people infected with hepatitis A could die from fulminant hepatitis, as we had seen. The risk of infection is associated with a lack of safe water, and a safe and effective vaccine is available to prevent hepatitis A, which I think my next faculty will take care. And I would invite now Dr. Rajshekhar sir to continue the module. Yeah, Dr. Rajshekhar sir. Yeah.
Yes, sir. Ready, sir? I'll start sharing my screen, sir. Sir, visible now?
Yeah, yeah. Go for slideshow, sir.
Yeah.
Dr. Rajshekhar is also part of our ACPIP team this year. So welcome, Dr. Rajshekhar.
Thank you, sir. Thank you, sir. The slideshow is. So these slides are being seen?
Slides are seen, but you have to go for slideshow. See, you are on the top.
Click on the slideshow on the top after animation and review. See, on the top there are animation, slideshow, review.
Just
click on slideshow.
Which one there?
No, no.
On the
but
top,
now it
there
is
are
not moving.
home, insert, design, transitions. Are you able to see?
Your voice, my voice is
Rajsekhar sir, just on the top of the thing, where there is the home is highlighted, you go on the right side of home. You can see, go to the transition, animation, and then slideshow. Go, just slideshow now. See, there is a slideshow written.
yeah.
Click on it.
That one was affected with it.
Double click.
Or in the below there is a cup shaped thing. You can click over there also.
I'll join with other then. Let's see.
Slideshow, it's not moving. You click on it twice. Double click.
Not moving, sir. And ready.
Acha, you can go ahead with it. Go for the first slide. Go to the first slide.
Let's see. Others I join from other.
Can you name the slide? Then I can download and I can present.
Yeah,
What is the
hepatitis
slide name?
epidemiology model. Because I'm connecting from the other one. Shall I stop and then I'll start once more?
Dr. Rajsekhar, if you want, I can also slide share and present the same presentation if you want me.
Yes, sir, 1 minute. Now, okay, sir?
Dr. Rajsekhar, if you want, I can also share the same slide.
Now, okay, sir?
Yeah, now it's
Yes, sir.
okay. Go
It's
for
better.
Go to the first slide. This is the first slide.
Yeah, this one is.
Okay, fine.
Slides have come, but this is not. Yeah. No.
Yeah. Fine. Yeah, continue, sir.
I'll stop the other one. Yeah, now it's good. One minute. Okay, sir. Good evening, sir. Sir, able to hear? Hello?
Yeah, we can hear you, sir.
Okay. I'll stop the video, then the quality. Good evening, everybody. First of all, my heartfelt thanks to Central IIP team, Dr. Ramesh sir, Dr. Upendra sir, Dr. Piyush sir, and Dr. Vineet, Dr. Shruti Mishra, Dr. Ashok Datta, Dr. Kaustubh Naik, and Dr. Satapka Gangre. And thanks to the coordinator of the module, Dr. Bhaskar sir and Dr. Sachin sir, who have made immense efforts to disseminate this module throughout the country among all the pediatricians to know about the knowledge of hepatitis B. I finally thank Team IAP West Bengal, Siliguri, Rupashi Bangla, Dr. Shushmita Banerjee, Dr. Indrajit Chaudhary, Dr. Shukir Bhaumik, Dr. Tanushi, Dr. Shama, Dr. Swarupananda Naik, Mighty, and Dr. Kalpana Datta for giving me this opportunity to be with you all this evening. And my co-faculty member, Dr. Atanu, Dr. Arun, Dr. Pinaki, and Dr. Devji. Finally, thanks to the fellow academicians who have been here with us this evening and the host. First of all, coming to this module of epidemiology, as a medical students, as a clinician, we never think about this epidemiology. We are what we had rather say we get bored of when we see about the SPM chapter. But of today, why epidemiology is important in disease aspects also. Hepatitis A, we know it is a very most of the time is asymptomatic injury, and that's why we don't bother about it because the complications are less. We don't bother. Is it that the condition? No, we should bother about this. Many things come up. We know about the epidemiology. Once the epidemiology, we'll know the importance of this subject. So what are these cases? 1.5 million clinical cases are seen. Is it correct? No. The rate of infection is much. because it is unreported. You see a case, I see a case, everyone sees it, but we don't report it. So it may be 1.5 into 10 times more the disease burden. So yes, there is a disease burden which has been not reported. Okay, let's see what are the reported cases. In the reported cases, 1.5 million, and the global disease estimation is that acute hepatitis A infection increased 4.2% in 2005 and 2015. So yes, there is an increase that is evidence as to this. And this increase may be 10 times more. So one important aspect is increase in the disease. Second important aspect is there any problem in this disease? One is a fulminant hepatitis. If fulminant hepatitis failure is problem, then what is the incidence? If I see 0.14 to 0.35% of hospitalized cases, total burden 0.5, noise. Now, if you take as per patient, if a patient suffers from fulminant hepatitis, it is 100% for him. A disease which can be prevented and by simple vaccination. Why should taking the global scenario 0.14, but the child is 60%. So when the disease can be prevented, don't take it a back disease. It is a cure front disease, and we have to prevent this. And that too, fulminant hepatic failure increases as the age increases. Let's see, what is the age increase incidence? What is the next thing I should know about epidemiology? What is the epidemiology tells us that there is a disease, there is a prevalence area. What is the meaning of high prevalence area? What is the meaning of the low prevalence area and intermediate prevalence area? All things. What is the meaning of this? So the prevalence is high prevalence area. What is more than 90% by the age 10? It is known as high prevalence area. In intermediate prevalence area, if 50% of the population have immunity by 15 years, it is known as intermediate prevalence area. Low prevalence area, 50% have immunity by age 30. And very low prevalence area, less than 50% have immunity by age 30. So you see, it are more dangerous. Low prevalence area. In low prevalence area, age 30, they are susceptible. And the second important point Dr. Atul was telling, if the age group, the higher age group, the higher it is symptomatic, the higher it is mortality and mortality. Complications are high. So you see, so we should not have a low prevalence area. And what is in Indian culture here? Yes, again we go to the endemicity. If you go to the endemicity, it is divided as high endemic, intermediate endemic, and low endemic. High endemic means more than 50% of the population. Intermediate endemic means that 50% are positive. Low endemic is less than 15% seropositive. So why should I know about this high, intermediate, low? Yes. Importance is now in India, we are shifting of epidemiology. If there is a shift in epidemiology, the clinical knowledge has to be also taken into consideration. So India is a mixed culture now. High endemic and it is also in a low endemic area. Why this has occurred? So high endemic, Africa, then Central America, South America. What is happening in India? In India, the two most populous countries have shown a rapid socio-economic development in the last years. So many high endemic areas for hepatitis A, B coexist with others, making a transition to the moderate. We are in high endemic, but now we are going to moderate. Let's see the burden of hepatitis A in India. So the burden of hepatitis A is, suppose you take the total hepatitis A cases, 2011, 2012, 2013. If it is for A, you say it is increased. Test for hepatitis, total hepatitis they have taken. Tested for hepatitis A, it is there, it is increasing. And if it tested for hepatitis E, it is also increasing. So these are the burden, there is increase. So this graph also tells that the hepatitis A has been on the increase. This proves us, because we are clinical evidence one, and our graphs also studies prove that hepatitis A is increasing. So what is the epidemiology? Who is the reservoir? The human being is the reservoir. And once we know the reservoir, how it is transmitted from human to human is by the fecal route. By knowing the fecal route, and we can understand the disease, that sanitation is helpful. With the sanitation, disease spread can be stopped. Next comes the question is, when some person suffers from hepatitis A, what is the chance when he'll start spreading the disease to others? Communicability is 2 weeks before to 1 week after onset of symptoms. So before the patient becomes symptomatic, he has started spreading the virus 2 weeks, 15 days before, and he'll shed the virus 1 week after that. So this is important because anyone, suppose most of them, many are asymptomatic, so we don't know he's asymptomatic, he's spreading the disease. Start symptoms, suppose tomorrow today he gets a jaundice, means he has already transmitted the virus to many people, and he'll still be transmitting the virus next 1 week. So let's see what is the clinics or the evidence-based medicine tells about the so, pandemic. What is that? There is a shift from high to intermediate endemicity. High is the intermediate market. From the decreasing number of adolescents and young adults with prior exposure from an increasing number of infections. Adolescents now, if you see, seropositive rate is less in them. Why the seropositive rate is less? Because our sanitation, we have cocooned them in our way. So the middle and social economic and high social media, they have cocooned the children, they have got cocooned. So not getting exposed to the process of hepatitis A virus. Still in rural areas, it is in highly endemic. And what is the important? So now we are in the intermediate zone, and rural area is the high endemic zone. So what is the difference? So we are in intermediate zone, we are susceptible to disease, and the high endemic area, rural areas are transmissible. They are happy. But if we go there, if any adolescents go there, if he's not vaccinated and he doesn't have immunity, he goes there during the trips, he'll get infected. So that knowledge is important. So increasing evidence of shift from high to intermediate endemicity in high income. So antibody, what have done? They have done an antibody testing. Low non-adolescents and young adults. Example, around 80% in Bangladesh and 55% in 5 to 15 years in India. Lower antibody titer means the more the chance of exposure, more the chance of symptomatic disease, more the chance of complications. So HIV is responsible, if you see about that, responsible for more acute viral hepatitis predominantly in this age group. Then comes the question is hepatic outbreak. Everything was going well, and a scenario led to an outbreak of hepatitis. Like if he goes to a hotel and more than 2 people have got any or something disease related to hepatitis A, we call this an outbreak. Has then outbreak occurred in India in the recent part? Yes. So number one, 2013 in India, there was an outbreak in Lucknow. 267 cases were documented and the transmission was fecal. Then there was an outbreak in 2014 in Mylapore area, fecal transmission. What was the source? Was contaminated water. Then came in Kerala, affected oral transmission, food from a newly opened. Now, our children go to the hospital, so that's why we should give the vaccine and send them to the hospital. Otherwise, it is difficult because they are open in our scenario. Then comes the question is, as per the latest data from British Pediatric Surveillance Unit, let's see, if there is an acute viral hepatitis, then what is the chance of acute hepatitis A? Acute hepatitis A cases are 29%, hepatitis B virus are 4%, otherwise at 23%, and 33% are non-identified. So 37 hospitalized hepatitis A virus cases. If you take the history, where did they go somewhere? Yes, 70% had traveled, but 8% had been vaccinated. 12 was there, and they were not prevented from vaccine. Not given vaccine. So they got the disease. In India, let's see the scenario. 2/3 of the outbreaks of hepatitis are reported from rural areas. I told the outbreaks, when you go there, it is there. Among 50%, 56% outbreaks with known etiology, 33% hepatitis A and hepatitis A. Most of the outbreaks, the study shows that it is because of we have to prevent this disease. Major outbreaks of hepatitis A, I already told you, 2002 to 2004, and 2004 in Kerala, 2007 in the same line. Already told by Dr. Thun, hepatitis A, everyone knows all the symptoms, nausea, vomitings, and the spread by it because it is a fecal roots, hand to mouth, so they have to sanitize, they have to clean their hands properly, and before taking food, and from the palm to the plate, everything should be sanitized. Then comes the question. Earlier, the age group asymptomatic. The age increases because more symptomatic fever in all like a common viral disease. Jaundice helps us to think that yes, it is. So, what is the pathway? What? So, finally, what is hepatitis a problem? It is yes. It is not a problem. It is. It causes some problem. It causes symptoms. It causes. We don't want a disease. This because we can prevent this disease. Hepatitis A resolves completely in greater than 99% of the cases. Relapse cases are reported in 3% to 20% of the 20% of the clinical cases. Suppose we go to the case that I was telling always the adolescent as the age increases, the fatality rate. Let's see coming to the percentage of that. In the coming to the percentage, 0.1% among children less than 0.3% among persons 15 to 39 years of age, 2.1% among adults aged greater than 40. As in age increases, the case fatality ratio because of hepatitis A increases. Permanent hepatitis, yes, I've told you 0.13%. Yes, it is rare. But once someone gets permanent hepatic fever and he is in high risk, there is a chance of mortality is not accepted today. You have to be very careful about this. Prevalence study, zero prevalence study also suggests the same. There was a study done taken in Kolkata, Pune, Delhi, and Chennai. So that also showed that there is a changing in So if you go for the age-wise seroprevalent data, the seroprevalence is age-wise specifically. This is the seroprevalence which is as per that. So finally, we know what is that there is a change in epidemiology. Because there is a change in epidemiology, what we are finding in India is that large pockets of susceptible children, that's the immediate endemicity and risk of there are pockets which throw the infection and the severity depends on the age. So the younger age group, better asymptomatic, the older age group, symptomatic, morbidity, mortality. Finally, to conclude this, India currently has pockets of high endemic and low endemic. There is a risk of hepatitis A in older children and adults, and exposure in low endemic population can be taught. So we have to now, the country has to make the country, it should be totally low endemic. Mixture is always a problem there. This now we are in a state where we are a mixed continent, which is subcontinent, which is in mixed. So global prevalence of hepatitis infection predominant in the Asian subcontinent. What does that say? That total prevalence of hepatitis infection has increased by 4.2%. This is a thought-provoking. HIV infections are often self-limiting in children, which I will show you, but can be acutely symptomatic and fatal in adolescents and adults. Epidemiological shift of hepatitis A increasing disease burden in adolescents. Significant socio-economic development in India over the last few years. There is a lead with improvement in the standard of living and hygiene condition. So, age acquiring HIV childhood to adolescence shows in India prevalence of anti-HIV antibodies in adolescents is 55%. So there's a 20% decrease in anti-HIV seropositivity has been noted over 10 years in children history. So because there is a seroprevalence is decreased, so it's a matter of 3.5-fold increase in incidence of acute viral hepatitis in adolescents is greater than 15. So this has increased. 2-fold increase in incidence of acute hepatitis A virus infection in adolescents is less than 20 years from high socioeconomic class. So you see the class, you see age, and you see the seropositivity. All there is a change in it. So this is the scenario today. So you are prone to get exposed to hepatitis A virus because of the food handlers and no proper sanitation. No one can stop this. And the era, the generation, the era is more inclined towards eating food outside. Come to us every day, parents tell us that they don't want to eat inside house, they want to go outside, they want to eat outside. When at least prevent hepatitis. Can I avoid it? No, impossible. So then why not take it vaccinated to prevent hepatitis infection? So what has the WHO provision paper told? WHO recommends that vaccination against hepatitis A virus to be integrated into the national immunization schedule for children aged indicated on the basis of incidence of acute hepatitis A change in endemicity from high to intermediate and concentration. Countries with improving socioeconomic status may rapidly move from the high to intermediate hepatitis A. In these countries, a relatively large proportion of the adult population is susceptible to hepatitis A virus. Large-scale hepatitis A vaccination is likely to be cost-effective and is therefore endless. So I've told you, inclined to eat outside, can't prevent it, so better take vaccination and be out of hepatitis. So India currently is high endemic, low endemic, hepatitis A. Older children and adults, exposure in low endemic population. Both in a scenario where is vaccination and hepatitis A effective? Yes, it is effective, and the further details will be held in the next module. Thank you very much. Thank you very much. Dr. Ram sir, finish sir.
Yes, sir. Can I take ahead for the next session, sir? Next
Yes, sir, you can take. You can.
Okay. Thank you.
Thank you,
Shweta,
sir.
I will be sharing my slides. I hope my slides are visible, sir.
Yes, sir. Slides are visible.
Can I start my presentation?
Yes, sir. Please continue.
Thank you. Next module is diagnosis and management of hepatitis A and acute liver failure. At the onset, I thank the Central IP team and Dr. Bhaskar and Dr. Sachin for giving me the opportunity to speak. I have seen hepatitis growing from my PG days and now coming to the era of liver transplant. It has been excellent because earlier we had very few sources to manage hepatitis A acute liver failure. It was really difficult for us, and really this era has given us a lot of opportunity. Introducing the presentation, the hepatitis A infection is a self-limited infection, and average incubation period is 30 days, and most of the children are asymptomatic, and HAV does not generally go into a chronic liver disease. Diagnosis, first and foremost infection everybody does is a liver function test, which are generally raised. SGOT, SGPT are raised, and we can do an INR generally to prognosticate, and it can be a clinician's decision whether they want to do a PT INR or not, whether you feel that the patient is going into a symptomatic phase, not recovering, or patient is sick, but generally everybody should perform a PT INR to look whether the child is having a severe disease or not. That is very important. So we study the HAV antibodies. We do an IgM HAV, which appears within the 5 to 10 days of the symptoms of onset and can persist for 4 months. Sometimes if you do it in early phases, you can have a false negative IgM HAV. So IgG antibodies generally come later on, after say around 4 months of age, and can persist later on also. Ultrasonography, we never routinely from. You should have some clinical evidence or some suspicion whenever you feel that on clinical examination you are having hepatomegaly, splenomegaly, clinical evidence of some ascites, we can go ahead and go for doing an ultrasound. Ultrasound generally helps us to rule out a chronic liver disease underlying, and this can be the first and foremost investigation which will help us to do further investigation for the CLD. What findings we can have is, we can have an hepatosplenomegaly, we can have some gallbladder thickening. Gallbladder thickening, generally if we found, it can be associated with only acute viral hepatitis. There is no association with a chronic liver disease. We can have some portal nodes which are raised in size. A very important finding which is there sometimes is the periportal cuffing. We can see a increased brightness and clear visualization of the portal vein radical walls. This is a very important finding which sometimes you find in a ultrasound of a hepatitis A positive child. Treatment, we don't have any specific treatment for hepatitis. It's a self-limiting disease. Recovery from symptoms following infection may be slow and sometimes may take weeks or months. We should try to avoid unnecessary medications, and normally we can give symptomatically paracetamol or acetaminophen. Hospitalization, it's a very common trend to hospitalize sometime in a few places. That child is vomiting and persistence of some prodromal symptoms, but usually we don't need hospitalization, and the child is definitely being taken care in a home care environment. Only cases where we need hospitalization is whenever we suspect an acute liver failure. Therapy generally is aimed to maintain an adequate comfort and nutrition of the child, and sometimes we can also look for if replacement of fluids in case the child has persisting vomiting or diarrhea. Coming to management in detail, supportive care, adequate hydration is to be done. We have to take care of nutritional support because there is lots of hepatitis and lot of satiety. Antiemetics can be used in cases of severe vomiting. PPI has a plus minus role. I have not been using PPI for long in patients of hepatitis A because generally the prodromal symptoms, they subside after the onset of jaundice, which is a period of 3 to 5 days. After that, these prodromal symptoms of vomiting are not there. Antipyretics can be used initially whenever there is high fever. Cholinergic agents, yes, if you have suspecting later on the onset after 10 to 15 days of onset of jaundice, you can have some pruritus, which helps definitely in reducing the pruritus. The first mode of treatment is ursodeoxycholic acid. We should definitely monitor INR, and we should do a follow-up liver enzymes after, depending 4 to 6 weeks. Doing an earlier liver enzyme will not help much in the course of management. Coming to acute liver failure, this is a very important entity because hepatitis A associated acute liver failure is significantly common. Pediatric acute liver failure study group has defined PALF in infant and children according to the following criteria. When there is no evidence of chronic liver disease and there's a biochemical evidence of acute liver injury. When we have corrected after giving vitamin K, the coagulopathy defined as, which is an INR more than 1.5, and when there is no presence of hepatic encephalopathy and we have INR more than 2, we take it as an acute liver failure, and for this the child definitely needs hospitalization. Common etiologies as per the data available, we have hepatitis A as the most common culprit in the Asia. Other factors can be indeterminate. We have a drug-induced liver injuries, of which acetamin and valproate are the most common culprits. Wilson disease, very commonly seen. We have very much case reports, and also autoimmune hepatitis if you have a female patient. Mortality is significantly high. It can go to as high as 50%. Study which was presented in 2017 by Dr. Seema Alam and his team, which has shown very clearly that hepatitis A was a very common culprit, and she had 43 patients of hepatitis A which had presented with the most common viral hepatitis picture. Then we had intermediate, and then we had drug-induced, of which paracetamol was one of the most common culprits. Metabolic liver diseases were galactosemia and tyrosinemia. So jaundice to encephalopathy period was 0 to 120 days. Hepatic encephalopathy was seen in 88.9%. Most common etiology, as already said, was viral hepatitis, coming down to metabolic diseases and drug-induced. Poor outcome was seen with a high PLD and MLD scores at 72 hours. So whenever a child who lands to us with acute hepatic failure, we have to be very critical in looking at the patient. We need a definitive history, and we should go in detail. We should spend some time. So we should look for the time of onset of symptoms. What is the current mental status? What is the level of encephalopathy which the child is having? We should identify the viral hepatitis. We could ask for a history of prodrome. There could be fever. Whether there is a history of past blood transfusion, which could be pointing us towards hepatitis B. and whether there was use of any hepatotoxic medicines recently for fever or any other reason. Is there any history of Wilson's disease or any other illnesses in the family which can look for Wilson disease? There can be some acute infectious hepatitis, and there can be some deaths secondary to autoimmune conditions which may not relate to a liver condition. We can also look for some chronic liver disease in the family. We can ask for simple things like which we are more commonly seeing in families of CLD, like ascites. We can have growth failure. Sometimes we can just a simple history of pruritus can be taken care. In neonates, we have to look for congenital infections like CMV, and also we should be able to take some history of a metabolic liver disease. Evaluation of growth and nutritional status is especially important if we are suspecting a CLD. We can ask some history or evidence of coagulopathy if there's any bleeding in the past. We can look to the patient and look for hepatosplenomegaly and peripheral edema, which will also suggest towards a CLD. Looking for hepatic encephalopathy is very important. Other features of chronic liver disease can be looked for in a way of portal hypertension. Slit lamp examination very easily helps us to rule out Wilson's disease. In our clinical days, we were also able to look into the eyes, and we could see some evidence during our posting in hepatology for a KF ring. And sometimes if you can see KF ring, you will always remember KF ring. Investigations is the battery of tests followed by LFT coagulogram. Ammonia levels are done to grade the level of encephalopathy. Higher the ammonia levels, generally it's the severity of encephalopathy. We should do a CBC to rule out some kind of infection underlying. Renal functions are done, and next we should be doing some guided investigations for the diagnosis or etiological diagnosis. Suspected infective pathology, we have to do all the viral markers, A, E, and C. We can sometimes have dual infections with A and E. We should look for CMV and Epstein-Barr virus, especially in neonatal age groups. HIV 1 and 2 can also be done if there is suspicion. Wilson disease, everybody knows, by measuring the cellular plasmin level and looking for the KF ring, we can get a diagnosis. Autoimmune hepatitis, yes, it's a very important differential diagnosis for a CLD. We do ANA, LMA, and SMA levels, but alone, if you have you cannot do certain amount of tests in a patient. Doing only IgG levels and raised IgG levels definitely points towards an autoimmune hepatitis, and we can further investigate the patients with other battery of tests. Hemophagocytosis, we have to do a serum triglyceride, cholesterol, ferritin, and later on a bone marrow biopsy. Drug levels can be done in cases where we are suspecting a drug overdose. Treatment, all ABCs are to be done as we treat any patients in an ICU, a central venous line, take care of volume resuscitation. Please take care of the glucose part, because we generally try to give a high glucose drips in these patients. Vasoactive drugs can be used whenever you are suspecting any hypotension. Some sedation can be done. One important point is very important, that N-acetylcysteine, everybody knows as NAC, which has to be given in a dose of 100 milligram, to be given in all cases, irrespective of the etiology. Please make it a point that we have to give NAC in all cases. Prophylactic administration of PPIs can be done because of prolonged antibiotics, and many other things can be done. So the most important thing, now we don't have a CLD, we don't have any evidence of CLD. So please avoid using preparations of L-ornithine and aspartate. There is no role of lactulose in acute liver injury. And there's also definitely no role of any non-absorbable antibiotics. More commonly, we are using rifaximin these days. Please avoid using these medications because they have no role at all. A very important monitoring. We have to look critically to many things. We have to look for the vital signs, and more importantly, we should measure the liver span. We can put a mark, and we should gradually look at the liver span daily. Oxygen monitoring, generally it is stable, and we don't expect a respiratory distress in these children unless and until you have a fluid overload. Urine output monitoring is more important. Kidney are generally going to be affected later on. All electrolyte, blood gases, and blood sugar are to be monitored regularly. What can prognosticate us is only the prothrombin time. We should regularly monitor prothrombin time. We can initially monitor twice a day. If the prothrombin time is increasing and the INRs are going high and higher and the patient is deteriorate, the only point which can save the child is a liver transplant. Liver and renal function tests can be done weekly. So treatment, we treat all electrolyte imbalances, and the only treatment which I feel has been able to make the child better is to treat the encephalopathy part, the raised ICP which the child is having. In cases of severe encephalopathy, we are giving a 3% saline infusion to maintain the sodium between 145 to 155. And whenever there's a obvious neurological signs, you can see there is ICP, we have to give a mannitol bolus of 15 ml in a drip, and we should do a monitoring also, and we can repeat this boluses as and when required. Sometimes hyperventilation can be done to reduce the PCO2 further, and if there's no response to mannitol therapy, there are various therapies which earlier used to be used like hypothermia, phenytoin, and steroids, which have now scientifically proven that they don't have any clinical role. Coagulopathy, everybody knows how to treat. This is not, we have to give vitamin K irrespective to all, whatever the parameters we have. FFP replacement should be done only when there's a significant bleeding or we are trying to do an invasive procedure. Cryoprecipitates, if there's an evidence of hyperfibrinogenemia. Sometimes there have been usage of recombinant factor 7A, whenever there is a combination of prolonged INR and a fluid overload. Platelet transfusions, depending on the platelets, if they are low, and if there is a significant bleeding, would require transfusion, and usually the platelet should be below 10,000 to be given a platelet transfusion. Usually platelet transfusions would be given and required if there's an underlying sepsis or other complications have been there. So sepsis is the major cause of death. So we have to take all asepsis precautions in these patients in ICU so that your patient does not come into the hand of these bacteria. And definitely once they are there, so they are very, very difficult to take the child out of them. So you can have a gram-positive cocci, a gram-negative, and if there's a prolonged stay, definitely you can have a fungal infection superadded. We have now not supposed to use any kind of antibiotic prophylaxis when the patient lands to us in the ICU. We should avoid using them. We should wait, and if there's any clinical evidence, and then only we should go for treating with antibiotics. The treatment modalities same. We can use third generation cephalosporins, and in case not responding, go up to higher antibiotics of vancomycin and teicoplanin, and fluconazole can be added as and when required. Acute kidney injury, we have to regularly follow up with the parameters, and we have to look whether there can be simultaneously, you can be having hepatic encephalopathy and uremic encephalopathy. So we have to monitor the sodium and potassium and see evidence of any fluid overload. You can have evidence of pulmonary edema, and patients can go into a severe metabolic acidosis. In these cases, yes, you might require a dialysis at a certain stage. Liver transplant, yes, it has been come up as a boom, and there have been many patients who we have been able to save now in the country. There are at least 135 centers doing liver transplants, and yes, there are many centers with a good success rate, and now they are taking up patients of acute liver injury. Earlier, it was only cholestasis in child. So taking up a patient for liver transplant, you have to have an INR of more than 4. And indications are, as you see, if there is clinical deterioration and there is no improvement, encephalopathy is worsening, but we have to follow the King's College criteria, which is very important. King's College criteria was initially come up for only drug-induced liver disease, but now, as you can see, the criteria says that prothrombin time, which is more than 100 seconds, or an INR of 6.5. Irrespective of that, we have to take that patient up, or we have any of the 3 variables for a child less than 10 years, or a cause being a non-A non-AB hepatitis, which is primarily in our children is hepatitis B, if there's a drug-induced injury or there's an idiosyncratic reactions. So if there's a duration of jaundice before the onset of encephalopathy for 7 days, and the prothrombin time not as high as 6.5, but as a borderline 3.5, and we have a rising bilirubin. So jaundice more than 7 days, prothrombin time raised, and also bilirubin raised can also be taken as a criteria, and can move ahead and shift the patient for a liver transplant whether before the patient deteriorates further. Now, as we have finished the part of our management, now I will just go on to a few cases which are very interesting and very atypical presentation of hepatitis A in our normal day-to-day practice. We had there was a 7-year-old boy with fever, anorexia, jaundice, and there was an altered sleep cycle. On examination, had icterus. There was mild hepatomegaly. There was no there was no ascites. Had some encephalopathy. Was not responding. Outside, when they were managed, he was referred to with a high-colored urine, cola-colored urine, and was oliguric. Lab parameters as described was bilirubin of 8, OTPT were elevated, all the enzymes elevated in thousands, 1400 and 1600. Albumin was 3.4, a bit low. INR was slightly raised, 2.3, then normal. Hepatitis A IgM was positive. Ultrasound, as I told you, can show an evidence of some edema on the gallbladder. Hemoglobin was low, TLC was raised, haptoglobin was low, and the peripheral blood film was suggestive of hemolysis. As already described by Dr. Atanu, we had the patient of G6PD deficiency. So we had a patient of acute hepatitis A presenting with G6PD deficiency and hepatitis A induced hemolysis. Supportive management was done and the patient was completely recovered. Another child, now to clearly mention, she is a 9 years old girl. She had presented with the prodrome of jaundice, vomiting, and anorexia. On examination, she had no encephalopathy, had only mild hepatomegaly and icterus. Enzymes were again raised to 1100 and 1300. Albumin was within a normal range. Hepatitis A IgM was positive, similar picture of edema. Everything was normal. Patient was fine, managed with supportive, and no dietary restriction was done, and patient was discharged. Now the child comes on follow-up after 3 weeks. She had significant pallor. She had developed petechiae. On examination, had only pallor and petechiae, but there was no hepatosplenomegaly. Labs were done. People were worried. Yes, what happened? Hemoglobin came down to 4.6, a normocytic, normochromic anemia. Corrected retic count was 0.4%. TLCs were also low, 1300, and total ANC was 500, and also the platelet count was 2600. So we had a pancytopenia. The further examination showed DCT was negative, HPLC normal, autoimmune markers negative. All other parameters, B, C, and everything was negative. Going ahead to dengue serology, scrub serology, everything was negative. Bone marrow was done, which showed a hypocellular manner of less than 5%. So we had a patient with hepatitis A and associated aplastic anemia. Initially managed with bloods and platelets transfusions, but as she did not show any improvement, cyclosporin was started under the guidance of a pediatric hematologist, and the child recovered in a period of 4 weeks. So some patients of hepatic A induced aplastic anemia might require hemopoietic stem cell transplantation in a long-term follow-up if necessary. So another interesting case, we have seen a very few cases earlier now. Now the child has come us with 8 years old. Now she had jaundice, and now the only interesting find is ascites. Clinically, if you can detect ascites, it's very good. On examination, she had a firm hepatomegaly and a spleen. So you have a combination of ascites, hepatomegaly, and spleen. Hemoglobin is 6, DCT negative, bilirubin raised. Enzymes are within the range of 600 to 500. Albumin here is low, INR is deranged. So albumin low, INR deranged, hepatosplenomegaly, ascites. Ultrasound done, showed portal hypertension. Definitely we have evidence of a chronic liver disease. Now IgM was positive, though we have a case of very classical case of acute on chronic liver disease. Ceruloplasmin was done, which was low, KF positive. So diagnosis is very clear. Wilson disease with acute hepatitis A. Very, very difficult to treat these patients because these patients generally land up into acute hepatic failure. But luckily, we started this child on D-penicillamine and the child recovered and is on a regular follow-up. This was a very good thing that the child is now currently able to do good, because most of the hepatic liver transplants now done presenting with acute liver failure is one is Wilson disease, second is autoimmune hepatitis, which have a very common presentation, which we have to take care, and early treatment in these patients definitely help us save their children. A small slide to which we are the most commonly used drug in hepatitis A for pruritus is UDCA, which is ursodeoxycholic acid. So whenever we suspect and we do the assessment of the pruritus criteria and a 5D score, we can start UDCA alone, or we can start it with cholestyramine and wait for the response. If there is no response, we can add rifampicin, and we can wait further for 4 weeks. And if there is no response, we can add naltrexone and ondansetron later on. So please make sure that we follow this pattern of UDCA, rifampicin, naltrexone, and ondansetron. We should not do up and down. And sometimes we can use cetirizine or hydroxyzine if required. Prognosis, as you can say, acute liver failure has a very, very poor survival of at least more than, we have a mortality rate of as high as 50%. Better prognostications, and also the most of the liver transplant success has been with hepatitis A and paracetamol overdose. Some few patients of ischemic disease also had a good prognosis, but we have rarely seen these patients. Poor prognosis is definitely a drug-induced hepatitis B in an intermediate case. Prevent as much as we can. We can prevent hepatitis A by improving sanitation, food safety. Immunization is the modality to coming up in which we can save a large group of children. And the spread of hepatitis A can be reduced by sanitation, proper disposal, improving hygienic condition. Obviously, sir, Corona nowadays has taught us in a huge way that how these hygienic conditions can be maintained, but still we are a long way to go. Coming back out of Corona, we are back to all these things now. Hepatitis A vaccines can definitely help us improve this. So take-home messages, most of the hepatitis A infection is self-limiting. All the patients infected with hepatitis, acute viral hepatitis, should be followed up till they have a normal liver enzymes. Hepatitis A definitely is the most common cause of acute liver failure in a child. Patient of ALF should be closely monitored and should be referred for liver transplant at the earliest. Thank you very much. I think we can take up the second module. Dr. Pinaki, I hope you are the next part. And
yeah, Pinaki, I think it's your module now.
Yes.
Welcome, sir, on the board.
Yeah.
Hello.
Hello, sir. Sir is not there. Indranil, sir.
Indranil, sir, is there, sir, but I think
Technical issue.
Pinaki, you can start screen sharing.
Okay, okay.
Dr. Pinaki can start.
Okay.
Sir, good evening, sir. Most welcome, sir. Pinaki, sir.
Yes.
Please start your session now.
Pinaki is
Most are, I think, busy.
Pinaki is busy organizing the East Zone Pedicon in Silchar. Sachin, if you give us more modules, then we will be invited to that.
Sir, definitely.
Yeah.
Give us also, sir, opportunity to come there.
Yeah. Obviously, I will be happy to welcome each one of you there. So my screen is visible
No, no.
No, sir.
Okay, I go for the screen share.
Yeah. First go to screen share, তারপরে তুমি ইয়ে করো. Then you can do that. Screen sharing में click करो.
Yeah. It's coming.
Yes, sir.
Yeah, it's not
Slide
there.
mode show.
Yes, very good evening, each and everyone here. And it's really a continuum of the hepatitis A module by my learned previous speakers. I really thank each one of the organizers, Dr. Bhaskar Sinha sir, and the whole team, Dr. Patel, for giving me the opportunity to be one of the here facilitators. Now, hepatitis A, the vaccine, as we know, is the cornerstone of the prevention. As we have already discussed, that there is an epidemiological shift of this infection from the lower age group to the relatively higher age group. And why it has become that India has become from the high endemic that is going into intermediate and the shift to the older age group where the complications are relatively more. So that is really a problem for us, because this age group will be more and more getting affected, and there will be more chances of hepatic encapsulation for liver failure. Now, having said that, we know that the treatment is limited. We have to prevent it by best is the sanitation and improved hygiene. That is well known. It is more to be practiced at the community. And what is above that has to be done is the vaccination of the kids. Now, WHO recommends the vaccination against hepatitis A virus to be integrated into the national immunization schedule above the age of 1 year. So what we want, that beyond infancy, maybe the first birthday, the birthday gift should be the hepatitis A vaccine to each and every kid. It is indicated on the basis of the incidence of acute hepatitis A, as we have discussed, change in the endemicity from intermediate and considering the cost effectiveness. Countries with improving socio-economic status, they are rapidly moving from the high to intermediate. In India also, we are seeing, at least in the high socio-economic group, there is demographic transition, and probably this is a good sign. One way there is demographic transition, but the problem is that there is also pockets of high endemicity as well as low endemicity. So older children and adults are getting more exposed, and obviously, as we know, that the incidence of complications of so-called the simple jaundice or hepatitis A is higher as we escalate the age. So there is no active treatment of the hepatitis A virus. That is, we have learned prevention is the best key. So it is endemic in India. 50% of the children of ages 1 to 5 years were found to be susceptible to the virus. Now, as it is predominantly a fecal-oral route, and having said that, improving the hand hygiene and maybe more and more use of the bottled water, that has reduced the rampant jaundice or the gastroenteritis related cases. But Hep vaccine has been found to be one of the most effective ways that has been evident from different countries as we go forward succeeding. They are very effective. And what has been found that if we see the vaccine doses in million, we have increased, the vaccine doses have been increased, the annual incidence that has been shown by those yellow pockets, that we are coming less and less. So this simple bar diagram showing that as we escalate the vaccine doses, the incidence of the hepatitis A is coming down. So this is what we have learned from so-called developed country like USA. What we have found that gradually hepatitis A incidence is coming down. The cases, once we are getting more and more vaccines. Same with the vaccination program was launched in Argentina with this bar diagram in 2005 showing 27,773. And within 2 years, there is a steep lowering in the incidence. So also in our neighborhood of China. So these are really an important clue, an important message from the international forum that if this vaccine is introduced early and to each and everyone in the national immunization schedule, there will be much more that we can save in the resources. So this has been a stark reduction in the cases of hepatitis A vaccine. Now all we are vaccinating, we know there are two types of vaccine. Two formaldehyde inactivated vaccine that has been prevalent from long by a renowned company, and the live attenuated vaccine. Now, all these vaccines contain antigens derived from attenuated HEPA strain grown in cell culture. The nucleotide and the amino acid sequence of these strains are approximately 95% identical. So what we get that this lab is a replicating vaccine, and non-replicating vaccine has been the inactivated or the subunit vaccines. Now we were more comfortable because it was the inactivated vaccine from a leading giant, from an MNC house, and have been used in the private sector, of course, about this non-replicating vaccine. It has been assumed that live attenuated vaccines are superior to the non-replicating vaccine in terms of quality of the antiviral immunity response, the level of the protective immunity, as well as the duration of the immunity. These all three hallmarks are showing that this is really very beneficial if we go for the lab, and that is the live attenuated vaccines. And more essentially, live attenuated vaccines are much cheaper to their inactivated component. Although most current vaccines induce antibody-dependent immunity, many vaccinologists still believe that a live virus vaccine is needed because we know that strong T-cell response will be required and there will be long-term memory cells produced. Now, vis-a-vis the difference, this lab is, if we are using a live attenuated vaccine, it is resembling natural infection, unlike inactivated vaccines, which does not resemble natural infection. It gives, in the live attenuated, continual antigenic stimulation, giving sufficient time for the memory cell production, unlike in inactivated vaccine. So this is very essential that we get both multi-pronged immunity, CMI, as well as humoral. That is comparatively only humoral immunity that is more in the inactivated vaccines. Same dose. Another issue is that live attenuated vaccines are same dose whoever are using. Only thing, we have to get the powder and have to dissolve it, because now only in the private sector, still now, it is the only one company which is marketing that is said to be blamed was it was a China-made vaccine. So those myths have been gone that quality is inferior. There is some issues with that, but still now it has been with vis-a-vis studies, in multiple studies, it has been proven. So many studies were there in another PPT that it has been found to be equally or rather no way less than the inactivated vaccine. The benefit is that this is cost effective and a single dose irrespective of the age. Now, again, continuing days, the live attenuated vaccine dose is low, single dose, no need for adjuvant. Now, this says that adjuvants occasionally can give more pain for the dose if we are using for the killed ones. And here there is no need for this. And the duration of immunity is more, humoral immunity as well as CMI is good, as we have discussed. And the age of administration is the golden. There is no confusion or controversy. This is beyond infancy. Or we can tell the first birthday gift from a pediatrician to its baby. So live vaccine provides both humoral and CMI compared to the killed vaccine. Now, what we get here, that the H2 strain of the HEP vaccine has been licensed for use. It has been used in so many countries. So this already we have discussed, but here also there is a gradual reduction in the incidence of the cases, whoever has started the vaccination program. Live single dose and inactivated 2 doses are safe, highly immunogenic, and possibly provide lifelong protection against hepatitis A virus in children and adults. This is the WHO position paper in 2012. Single dose regimen has been successful when started early. What we are getting from ACVIP, again, beyond 12 months, single dose, live attenuated, we are using the H2 strain. If we are using the killed vaccine, 2 doses, it is still the recommended from ACVIP. Now, again, IAP Guidebook of Immunization, there is no confusion. Beyond infancy, we can go for the lab single dose and 2 doses for the inactivated. Only points here to note that the separate 2 doses of 6 to 18 months gap. If we go from the first dose, in case of inactivated hepatitis A vaccine, usually we defer the second at the age of 180 days or beyond. But it should not and must not be beyond 18 months. If any defaulter comes beyond 18 months, it is better to start again with the first and second dose separately. So this is, there was a wrong issue. This has been specifically highlighted, not to be used. There was an error in one of the IAP modules that came in earlier. Just to highlight it, this has been given that there is no query about lab. There is nothing. This is for only inactivated if we go. So this is crossed. So this is in the error in the previous publication. Now, this is what is the updated applications, what we get. So data on the immunogenicity and safety of the single dose vaccine is very well accepted. We get it IAP Corrigendum in 2020. But we get the trade name has been licensed, Occurs BioVac A. This has been compared with the GSK inactivated, which is a very old brand of inactivated GSK, inactivated hepatitis from GSK. And vis-a-vis comparison, what we find, comparable immunoresponse seen in both the vaccines. So that has been found to be quite beneficial also. That is, lab was unduly blamed, and it has been found that we need a minimum titer of 20 units to have the sustained antiviral effect. But the geometric mean concentration from the single dose hepatitis A vaccine, from the live vaccine, found to be beyond 70 also, and persistently beyond 5 years. So this is very essential. The seroprotection level of more than 20 MIU per ml has been achieved, and it was quite beyond, it was quite above that minimal level. So there was no confusion about the performance of hepatitis A live vaccine or BioVac A. So significant reduction in the hepatitis A cases reported. Additionally, there was a reduction in the incidence of hepatitis A in the entire population because of the herd immunity. That is another very essential issue. We get the herd immunity if we're using a live vaccine, and this has been found with the live attenuated hepatitis A vaccine. It was found that more than 80% subject remain seroconverted. Above that we are getting it, we will get it continued beyond 10 years, 15 years, till now has been multiple studies. And the minimum cutoff of more than 20 has been attained most of the cases in the lifelong. So it was up to 5 months where the cutoff has been maintained 127.1. Again, any vaccine, if we are using, we must maintain the protective efficacy and the duration of the efficacy, the duration of the immunity. So this is maintained very nicely, has been repeatedly studied. So result of this 5-year follow-up study showed the single live attenuated vaccine that will provide long-term immunogenicity as per WHO position paper. Both inactivated and live vaccines are highly immunogenic, and immunization will generate long-term protective hepatitis A benefit. So this is really a very essential. This is administered as a single subcutaneous dose, and IAP SCVIP committee has already recommended a single dose of this vaccine. We have already discussed it. 2 doses for the killed vaccine, single dose for the hepatitis A live vaccine. And this is the IAP schedule in the chart. We get it beyond 12 months, single dose of the lab. If we are using the second dose only for the inactivated vaccine, this is very clear. For live, second dose not recommended. If we are going for the inactivated, that is around 6 to 18 months apart. So maximum 18 months is allowed. Better we go at 12 months and again at 18 months. So 2020 immunization schedule includes the changes to hepatitis A and the TDF vaccine. The row for here we want to show that for hepatitis A vaccine has been changed to a solid green bar. That is, we are getting that the schedule, if we go with that, those routinely recommended vaccine updated annually to reflect the most current. So what we are getting, that SCVIP recommends that we should go with the live attenuated hepatitis A vaccine single dose at beyond the 12 months, or the killed hepatitis A. If we are going for that, it is second dose at the age of at a gap of 6 months. So this is a very clean message, clear-cut message. So this is 16 IAP recommends live vaccine single dose or 2 doses of the killed vaccine. This is the basic message that we want to go it at the age of 12 months, start second dose for the inactivated, again and again repeated at 2 doses with a separate of 6 to 18 months. So lower cutoff is 6 and upper cutoff is 18. So catch-up vaccines for 2 doses for the inactivated, for the live vaccine, it is again reiterated that we get a single dose. Now, the issue is if a single dose live attenuated, highly effective vaccine is available, then why to go for multiple doses? So no extra peak should be needed, and preferably a single dose should be attained, and at a cheaper cost, we can have the more benefit sustainable for the community. So this is the message. Thank you. Thank you. Thank you.
No one is there, Pinaki.
I don't know anyone is there.
Nice presentation, Pinaki sir.
Thank you.
Devjit sir, you can start. Apunuda is not audio.
Yeah,
Is
Dr.
fine.
Devjit, you can continue.
Okay, fine. I'll continue. Yeah, good evening. Can you hear me? Can you see my slides?
Yes, yes, perfect. Go ahead.
Yeah. After detailed discussion of the hepatitis A by Dr. Rajasekhar, Dr. Pinaki, Dr. Otonu, and Dr. Sosin is already there. First, at the outset, let me thanks Ansel IAP, Dr. Bhaskar Sena and team, and Dr. Sosin Pilot, Dr. Otonu, and all West Bengal IP for giving me a chance to talk. In fact, that last few months, we are almost daily, Dr. Sosin is arranging hepatitis A module. It's going very well. Let me congratulate him at the beginning. We have already discussed by my earlier speakers regarding why hepatitis A is so important, why vaccination is so important, elaborately talked by Dr. Pinaki. We all know that hepatitis A vaccination is, by now we are convinced that is essential. In ideal scenario, we should immunize all the population if possible. Ideally, we know that hepatitis A was not very serious in children. Most of the children by 10 years of age get infected. India was very high endemic zone, but it is no longer so. And again, in even children, hepatitis A still remain the commonest cause of acute hepatic failure. So hepatitis A, we cannot take it very lightly. We should not, moreover, about form of mortality, there is loss of working days and all others. And India is moving very fast from high endemic to low endemic zones. So all children are not necessarily getting infected by 10 years of age. Many people get infected in adults and age group also. And in adolescent, it is always become, most of the time adolescent and adult become more serious than in children. So in ideal world, we should vaccinate almost all children. But if we cannot vaccinate all, then what to do? Should we vaccinate the selective risk people? And we all know it is being a waterborne diseases or fecal route transmission. Can you selectively vaccinate the food handlers? Will it be benefited? Let us find out the data. As we have discussed already, hepatitis A is an acute inflammatory liver disease caused by hepatitis A virus infection from close contacts in infected people. Due to poor sanitary condition, most of the population is exposed to the virus in childhood. At this age, the disease is asymptomatic and provides lifelong protections against the disease. That is what we were thinking, and we are not saying that it is still commonest cause of acute hepatic failure, even in children. But according to the global estimate, approximately 600 million cases of foodborne illness related to 31 pathogens are reported annually, out of which 14 million cases are due to hepatitis A virus infection alone, and 13,53,767 disability adjusted life is lost due to only hepatitis A. Due to rapid socioeconomic development in some areas and good sanitary conditions, pockets of the population are reaching adulthood without prior exposure to this virus. And at these ages, infection carries a higher risk of symptomatic disease and complications, including mortality. It occurs intermittently, that hepatitis A virus infections occur intermittently, epidemic occur intermittently, and is known to cause outbreaks with a trend of cyclic recurrences. Globally, food contaminated with hepatitis A virus accounts for 2 to 7% of all hepatitis A virus outbreaks. Infected individuals may require hospitalization, which places a low strain on individual household expenses, as we have already discussed. Again, let me see in the following slide the data from across the world. In India itself, most of the food handlers are adolescents and young adults who might be exposed to unsatisfactory environmental conditions and poor water quality. Today we are living in the digital era. The more and more people are using the Swiggy and Zomatos and all other, and to take outside food and outside food, we don't have to go outside today. We are getting all delivered at our home, and most of the people who are handling these Zomatos and Swiggies are the young adolescents. Outbreaks due to foodborne hepatitis A virus have been frequently reported in India, with adolescents and adults primarily affected. There's an interesting data. If we see the data, from 1991 to 2000, acute hepatic percentage of hepatitis A due to the acute viral hepatitis cases due to the hepatitis A cases is increasing in each year. You can see overall, this one is separate. Let me. This is the 1999 data. This is 2003 data. This is hepatitis A virus causes 15% of the all cases in overall acute viral hepatitis is due to hepatitis A infection. In 1990, in overall, in 1919 it was 5%, but it was gradually increased to 15% in 2003. But if we see our most vulnerable age group, 13 to 20 years, that is teenage group. If we see that in 2003, in the 1990, about 20% of all acute viral hepatitis are caused by hepatitis A. But in 2003, as much as 60% of all acute viral hepatitis in this age group is caused by hepatitis A. Similarly, in 21 to 30 years also, as many as 40% of cases of acute viral hepatitis in 2003 was caused by viral hepatitis A. So the age group of 13 to 30 young adults and adolescent age group is most vulnerable for acute viral hepatitis A cases, which causes acute viral hepatitis. Food handlers play a major role in preparation of safe food, and they may transmit hepatitis A virus to susceptible individuals if infected themselves. In India, lack of knowledge and awareness of preventing foodborne disease and practice of proper hygiene among food handlers is a major concern. According to recent census data, India has a population of roughly 1.38 billion, of which approximately 63.7% are 15 to 59 years of age and economically active. And we saw in earlier slide that this age group is the most vulnerable for acute viral hepatitis. Attack rates in adults and adults are high, and there is a changing socio-cultural behaviors in India. In recent years, India has undergone rapid socio-economic growth resulting from increasing trade and industry, increasing degree of modernization, and access to better education, health services, housing, nutrition, and technology. All these things lead to increasing disposable income. We have more money in our pocket. This has led to an unprecedented change in consumer behavior. More and more people are eating outside nowadays. This is again the same. This is again another very interesting graph. Percentage of respondents eating out in a week per age group. If we see the popular, this is less than 20 years and this is 41 to 50 years. Less than 21% eat at least 1 to 3 times per week. That means in every alternate day, 80% of the population, 80% of the population below 20 years of age eat at least 1 to 3 times per week in a restaurant. That is every alternate day. But if we see some percentage, even 5% of the children below 20 years of age eat more than 16 times per week. That means eat outside. That means about 2 to 3 times per day. In all other age group also, you can see that at least minimum 4 to 6 times, as many as 20% of people eating outside, and as many as 80% of people eat outside 1 to 3 times per week. National Center for Disease Control definition of an outbreak due to a foodborne disease is declared when 2 or more cases of a similar illness occur after the consumption of a common food, or the observed number of cases of a specific disease exceeds the anticipated number. According to the NCDC again, there are a total of 315 outbreaks of viral hepatitis between 2010 and 2013. And hepatitis A virus was responsible for 10 to as many as 30% of acute viral hepatitis cases and 5 to 15% of the acute liver failure cases in India. So what are the strategies to prevent food outbreak? We all know if we can supply good sanitary hygiene and water, good food handling, and collecting, food preparation, everything. If we can manage the food chain properly, hygiene chain, then no need to probably hepatitis A vaccine, or no, we will prevent not only hepatitis A virus cases, we will prevent all the waterborne diseases, will minimize all the waterborne diseases, if not come to the zero. But we know we are far away from that dream situation. We are far from it. Strategies to prevent hepatitis A virus infection and transmissions are urgently needed in the context. The phrase from farm to plate make food safe for food safety might be useful. We know we are still practicing many people outside defecation and all. So when we collect the food from grains from the farms, there may be contaminations of the stools and other dirty water. So if we have to maintain the food hygiene, we have to collect, to cultivate cleanly. We have to give clean manure. Then we have to collect cleanly. Then we have to wash the food. Then we have to prepare, and food who is distributing us. All the chain has to be clean throughout, as it could help in developing preventive strategy composed of different complementary measures, such as improving sanitation, access to clean drinking water, maintaining healthy food and water hygiene practices, and lastly, immunization. If we follow the first three, then we'll come a long way in succeeding preventing all the waterborne diseases, but we all know we are far away from this. Only thing which is in our hand, in our pediatricians or in doctors' hand, is immunization. First 3 points is not in our hand. Who declared that by 2030 elimination targets for viral hepatitis? Who has to keep 2030 has the target for eliminating viral hepatitis? So we have only 9 years in hand. 8-9 years in hand. So can we possibly do it? Possibly just improving the hygiene and supplying water to all, clean water and food to all. It is completely in government hands. It is not in public, it is in public hands. So what we doctors can do to achieve this goal is immunizing en masse to all. If not en masse, if we cannot do it by 2030, if we can vaccinate the selected people, among them food handlers, we will definitely succeed. The government India initiated National Viral Hepatitis Control Program, the Swachh Bharat Mission Campaign, and National Rural Drinking Water Program. These things may raise awareness, reduce morbidity and mortality, and provide safe, potable water for all. Regulation by FSSAI and Bureau of Indian Standards are available, and are continually updating food industry, and the public should follow this guideline from time to time. So vaccination we have already discussed. The importance of immunization of food handlers has also been demonstrated in the real world setting, as in the United States. Hepatitis A outbreaks was reported in St. Louis. The 2 restaurants and 1 cafeteria was responsible for that. That led to the implementation of the mandatory hepatitis A vaccination of the food handlers. So did it succeed? Yes. The case rate of hepatitis A dropped from 3 per lakh population during the pre-hepatitis A vaccination period to 1 per 1 lakh population in United States of America after selectively vaccinating the food handlers. Hepatitis A vaccinations has favorable cost effectiveness in middle income countries if they are high, intermediate, and endemicity. Given the shift from high to intermediate endemicity and the substantial cost of treating 1 hepatitis A virus case, that is $346 in India. Let's forget that. Don't discuss about the loss of the days, working days, and school days. Even cost itself is a huge for Indian population. Vaccination of food handlers to prevent the spread of hepatitis A virus across the country could potentially be cost effective. So as we have discussed, to immunize all the children after the first birthday, if possible, is the best idea. But if we have a long way to achieve that, selectively handling of the food handlers or other high-risk group may help us to achieve the elimination of hepatitis A by 2030. Thank you, sir.
Thank you, Devjit sir. I think Indranil sir is busy in the work.
Okay, yeah.
Most nobody is there. Okay.
Yeah, Sachin, I
AP,
think you can
Yeah, Dr.
sum up.
Sachin, kindly continue.
yeah.
Shall I share the screen?
Yes, yes. You please share the summary. Sir, Antanu sir, what are you speaking?
We can end after you sum up the.
Yes, sir. Yes, sir. Hardly 5 minutes.
Dr. Otonu.
5 minutes only. Yeah. Next. Good evening, everyone. Almost my co-faculties have explained everything in detail. I am taking just 5 minutes for brush up and this highlighting the peculiar points. We all know that hepatitis A is an inflammation of the liver that can cause mild to severe disease. The hepatitis A virus is transmitted through ingestion of contaminated food and water and through direct contact also. Almost everyone recovers fully from hepatitis A with having lifelong immunity, but few proportion of people have a fulminant hepatitis and they can die. Hence, we need to have a serious look over this disease. The risk of hepatitis A infection is always associated with lack of safe water, poor sanitation, and hygiene. A safe and effective vaccination is available for this disease. Hence, our motto is to vaccinate maximum people. Next one. Next. Next slide, please. Though hepatitis A is a self-limiting, every patient should be followed till the normal liver enzyme, which is very well explained by Arun Prasad sir. And it is the most common cause of acute liver failure. Hence, we need a timely referral for liver transplant. Next one. India is moved from high to intermediate zone of hepatitis endemicity because of improving the sanitation, improving the hygiene practices, and more vaccination. Hepatitis A case mortality increases as the age increases. Though fulminant hepatitis is rare, but high mortality is still there. India currently has multiple pockets of high endemicity as well as low endemicity. Hence, there is always a risk of outbreaks, which is very well explained by Rajsekhar sir. Next one. As Pinaki sir rightly told, we have two types of vaccine, live vaccine at the same time killed one. And the WHO at the same time, IAP also suggests minimum age for vaccination is 1 year. And for live hepatitis A vaccine, we need a single dose, while for killed one, we need 2 doses, which should be separated approximately 6 months apart. The dose is 0.5 ml. For intramuscular, for killed one, we have to use intramuscular route. For live one, we have to use subcutaneous route. Next one. Next. Hence, as Devji sir has very well rightly explained that improving the sanitization, clean drinking water, healthy food and water hygiene, immunization of pediatric population, adolescent population, at the same time food handlers, and stringent government policy for the food improvement in the food hygiene can ultimately ultimately we can eliminate the hepatitis A virus infection from the earth, which is our goal by 2030. Next one. Hence, clean water, food hygiene, mass immunization, these are the tools to prevent hepatitis A infection. Thank you for patience listening. Next one. Thank you, sir.
Shahrukh, can just give the vote of thanks for the module.
Thank you, sir. Thank you for giving us the opportunity. This is a nice module, very lucidly presented, and the take-home messages are very clear. We are very much thankful to all the faculties the central IIP, all state IIP chairpersons, participants, and all of them. We are very much thankful for giving us the opportunity, a small branch like IIP Paschim Bangla. Thank you, Sachin sir. Thank you, Arun sir. All the faculty members, and thank you, Indranil sir. Thank you, Kalpana madam. Thank you, Atanuda, for giving us the opportunity. We have thoroughly enjoyed the session and hope we can use this knowledge in our day-to-day practice. Thank you all. Over to Atanuda and Indranil sir.
Indranil, you're muted.
All the presentations done were very lucid and crisp. And I thank everybody on behalf of WBAP, all the presenters, the arrangers, and also all the DIP staff who were involved in the continuous process in which the video and audio both worked. Good night, everybody.
Good night. Good night. Good night.
Good night.
Good night.
Sachin sir, इस महीने तो और नहीं है?
Sir, अभी आपका हो गया sir. We have 2 more.
नहीं, आपको यही afraid. I always afraid that I will miss something.
No sir, no sir. We have finished. We have only 2 in Maharashtra. We are on 10th and no, 10, 14 and 15. 3 are still remaining. That is the end now. Yeah. Thank you, sir.
Thank you, sir. Good night.
Good night, sir.
Thank you. Thank you.
Thank you, ma'am. Thank you.